I'd like to welcome to the stage Pat Purcell from the American Academy of Pediatrics.
Good morning. I'm Dr. Pat Purcell, and I'm president of the Kentucky chapter of the Academy of Pediatrics. I'm going to talk to you this morning about the mighty M's, message, manage, and minimize as it pertains to adolescents and the opioid epidemic that's occurring. This presentation was actually created in conjunction with a grant that we received through Alan Brensel. The Kentucky chapter received it, and it's from the Kentucky Opioid Response Effort. So we do want to thank the state for helping us and giving us the money to be able to go out and spread our message. So I have no financial relationships to disclose or conflicts of interest to resolve pertaining to this specific CME activity, but I do, I do want to share with you that I currently sit on the Pfizer's Adolescent Immunization Advisory Board since June of 2018. So prescription drug abuse, well, as we all know, it affects all of us, as everyone has alluded to. What I'm going to try to present to you today is looking a little bit more at adolescence and what we can do. You know, how we can look at safe storage, how we can look at safe prescribing, and how we can look at disposal so that we can make a difference in the primary care setting. So our learning objectives, we want to understand the epidemiology and the neurobiology of adolescent substance use. I want to hopefully define what is an adolescent gateway so that we all become knowledgeable for that. We want to discuss opioid management strategies that are available, of course, in the state of Kentucky, and outline some safe prescribing and storage strategies and introduce some safe disposal outcomes. So here's our key takeaway points, and these are incredibly important. 1 in 4 teens actually report having misused or abused a prescription drug at least once in their lifetime. 2/3 of teens who actually report abuse of prescription pain relievers are getting them from friends, families, and acquaintances. Adolescents actually believe that prescription drugs are much safer than illegal street drugs because they're prescribed by a physician. Parents often do not discuss prescription drug abuse with their children. And we, as healthcare providers, we really need to recognize that we need to promote medication safety by the storage and disposal because that's how we're going to make a difference. So if we look at the epidemiology and the neurobiology of adolescent substance use, we can look at adolescent behavior specifically. Now, as anyone knows, adolescents, they're motivated to seek pleasurable rewards. They love to avoid pain, and they have limited ability in decision making. What we have seen, there's some current empirical evidence from the behavioral sciences that have looked more specifically at adolescents, and they differ from adults and actually younger children. So they're right in the middle where there are two ends of the spectrum, but they actually differ in 3 specific ways. They lack the mature capacity for self-regulation, i.e. kind of that emotional layability that sometimes adolescents have. They actually have a heightened sensitivity to external stimuli, i.e. peer pressure. They tend to have a little bit more response to peer pressure. And then they show less ability to make judgments and decisions based on future orientation. What is the future going to hold? What I do now will make a difference sometime in the future. So the combination of these 3 empirical behavioral attributes of adolescence unfortunately means that they have a tendency to participate in more risky behavior that affects, of course, not only themselves but anyone around them. So this is important simply because drug use at an early age is an important predictor of substance abuse disorder. The majority of those who actually started using before the age 18 and actually developed it by the age of 20. And 1 out of 4 of those who began abusing prescription drugs at age 13 or younger go on to develop a substance use disorder sometimes in their lives. If we look at adolescent beliefs, because I think it's important to understand their behavior as well as what do adolescents actually think, well, they believe that prescription opioids and stimulants are easier to obtain than marijuana. 1/3 of teens believes it's hard to obtain prescription drugs, and 1/3 believe it's hard to obtain prescription stimulants, which really is not a large amount. And then more than 1 in 5 teens say parents would not care as much as they were caught with an illicit substance versus, I guess basically because it's a prescription drug. And 1 in 6 parents, if we look at parental beliefs, believes using prescription drugs to get high is much safer than using illicit drugs. 1 in 8 parents believes it's okay if their teen were to take a prescription drug without a prescription. And 1 in 10 believe it's okay to do so if their teen were taking it to reduce pain. 20% of parents surveyed actually admitted to giving their adolescent a prescription medication they had on hand. And I suspect if we looked at every one of us in the room, either A, someone has given us something because, hey, I had this in my medicine cabinet, you might want to try this, I know you hurt your leg, things like that. It occurs with a great deal of frequency. Just to give you an overview, as the medical students of course know, opioids versus opiates, looking at whether it's a semi-synthetic, looking at hydrocodone versus heroin. And what is incredibly important is we really need to speak the same language if we look to discern what our adolescents are doing. And that's simply because we are looking to tailor the treatment based on where the adolescent is. So if we all speak the same language, then we can know what treatment options does this adolescent need to be funneled into. So when we look at misuse, it's the use of medication by someone without a prescription using more than what's prescribed, and then using it by an alternative route. If we look at, there we go, abuse, and this is the new Dsm-5 Criteria, and that's the Diagnostic Statistical Manual of Medical Disorders, which is what psychiatrists use to label any kind of psychiatric illness. When we look at that, it actually has changed with the Dsm-5. They combine some previous categories, but it really makes it, I think, more simple, because when you look at abuse, you can look at defining it as mild, moderate, and severe. You can define by the number of diagnostic criteria that are actually met, and you look at the impaired controlled social impairment use, and then the pharmacological criteria. So again, it offers us the availability to stratify someone to give them the best help that they need based on where they are. And then, of course, we have addiction, chronic relapsing brain disease characterized by compulsive drug seeking and use despite harmful consequences. Now, here's where it's incredibly important to look at the adolescent and look at the adolescent brain as it begins to evolve, because this will tell you why adolescents are such higher risk of addiction. If we look at the adult versus the teen brain, so most of the activity in the adult brain is in the frontal lobe. That is our thinking, that is our reasoning, that is our planning. When we look at the activity in the teen brain, it tends to be more centrally located, which is the pleasure, the reward center, going back to what I alluded to before. So there seems to be this imbalance between the teen brain and the adult brain, and that imbalance, that immaturity, I think tends to lead more toward the adolescent being at higher risk for addictive properties. Brain development during adolescence, again, going back to that prefrontal cortex. And again, remember, our organization of our thoughts, our weighing our consequences, assuming responsibility, and interpreting emotions. These are things that are very important for an adolescent when they're being offered some sort of a drug from a peer. This is a great slide. Magnetic resonance imaging, MRI, has now offered us the availability to be able to look at the functionality and the structural components of the brain. So this slide looks at the red, yellow are parts of the brain that are less fully mature, while the blue, purple are parts of the brain that are more fully matured. And you would anticipate in a 5-year-old brain, there tends to be, of course, a great deal of immaturity. Judgment, again, is not going to be central. The preteen brain, you're starting to see some of the blue, some of the more mature areas occur. The teen brain, definitely more. But here's what's important. Look at the 20-year-old brain. It still has areas of immaturity in it. So again, we need to take that into consideration as we deal with our adolescents. It's not always that they're just doing it. There is some intrinsic quality to their brain structure that makes them more sensitive to the risks of addiction. So what are some of the gateways to addiction in adolescence? Well, desiring new experiences is something that they want to do. They deal with problems, and that could be at home, it could be at school. Stimulants are sometimes utilized, of course, to obtain better grades, and then, as I alluded to previously, peer pressure. The National Institute drug looked at some of the reasons that teens actually use drugs. And if you look at this, 62% say it's easier to get from their parents' medicine cabinets. 52% say it's available everywhere. 51% say they're easier to have. Excuse me, when you look, 49%, if you get caught, you can claim to have a prescription for it. So it makes it a little bit easier for them. They're cheap, safer to use than illegal street drugs. So remember, there's still that thought process in an adolescent's brain that it's okay because they're prescription drugs. This, looking at 32% having easier to purchase over the internet, but what's important is the 21%, where really parents wouldn't care as much as if they were caught. So again, we need to look at parental beliefs as well as our adolescent beliefs. So the sources of exposure, dental prescriptions are the highest risk factor, so to speak. In fact, dentists and oral surgeons wrote for the majority of prescriptions for adolescents in the age brackets of 10 to 19 years of age. Now, this was not a deliberate act, needless to say, but if you kind of backtrack and think through it, who ends up getting them? Well, you look at who gets their wisdom teeth removed. And so about 3 million adolescents get their wisdom teeth removed in any given year, and 3,000 adolescents more than likely will go home with a prescription for some sort of a narcotic. So that tends to be one of the largest areas right now. Prescriptions for pain control due to sports injuries. There's a nidus, I think, on us as healthcare providers. We need to look at alternative pathways. As the CDC speakers alluded to, that is something that we are now being taught, whether it's acupuncture, whether it is physical therapy, whether it is going back to the basics of Tylenol or ibuprofen in our rest, but really looking at how we actually prescribe these. And then families, medicine cabinets, family members, and then of course our home. So 2/3 of teens who report abuse of prescription pain relievers, they are getting them from friends and family. 4 in 10 teens who have misused or abused obtain them from their own parents' medicine cabinet. And more than half of parents say anyone can access their medicine cabinet at any time. And 3/4 of teens say it's easy to access prescription drugs from their parents' medicine cabinet. So really a gateway is clear. So what opioid management strategies, what treatment services do we have available? What can we do? Well, we know that there's the opioid overdose deaths. We know that each year it's steadily rising. When we look at the Kentucky data for 2017, we looked at 1,404, with an increase of about 7.4% from 2016. Louisville, Lexington, and Northern Kentucky specifically hit hard. I think when we look to manage, we recognize and need to recognize that it's not a character flaw. Interact for Health, it's a nonprofit that's based actually in Cincinnati, Ohio, surveyed 20 counties around that area in Kentucky and Cincinnati. And what they found is that 70% of the adult Kentuckians surveyed agree with the statement that addiction is a disease process. So going back to what previous speakers have said, what Dr. Howard said, it is important to recognize, again, it is not a character flaw if someone has a substance use disorder. It's both physical, psychological, and it's chronic in nature. So we need to provide support for our adolescents. We need to look at discouraging current use. We need to look at reducing the effects in the intermediate risk adolescents. And we need to work with counseling to teach prevention skills. It is very important to address the mental health disorders that occur in teenagers. Teenagers with any mental health problem are more prone to painkiller dependence after receiving prescription opioids. There was an article published in March in JAMA from Quinn et al., and what he looked at was the increased risk of misuse in teenagers if they had been previously diagnosed with a mental health disorder and were on 1, benzodiazepine, such as Xanax, 2, some sort of a serotonin norepinephrine reuptake inhibitor, such as Cymbalta, or some sort of atypical antipsychotic, such as Abilify. So again, there's a risk associated with an underlying mental health disorder. So surveys of teens' parents are key. They can make an enormous difference and influence their children's perceptions of tobacco, alcohol, or illicit drug use. So what kind of tools can someone have in their office? As we look at ourselves as primary care providers, what can we do? Well, the Academy of Pediatrics recommends the screening to brief intervention and the brief screener for tobacco, alcohol, and other drugs. These are quick, they're efficacious, and they have good data to support it. The SBRT is the screening brief intervention referral to treatment, and again, this has some good data behind it. More studies have been done in adults where it has been more efficacious. There will be studies that will be done in pediatrics, but again, this is what the AAP currently recommends, and they updated their policy statement in 2013, giving a more fine-tuned explanation of how to proceed to use this in your office. So you can build your knowledge, you can do your pediatric waiver training. I think Dr. Purcell is going to discuss that, and that is on the AAP website so that someone can get additional training. There are webinar recordings that are also on the AAP website. I would encourage anyone, if you have some time, to take a look at them. And there's training simulations which look at how you can do motivational interviewing with your adolescents. Kentucky resources available, the Kentucky Help Call Center, the Find Help Now Kentucky, and of course the Kentucky Department of Drug Control Policy. So let's look at some minimization. What can we do? Well, we can do medical education about opioid analgesic prescribing. That is occurring now. We're all becoming more aware of what we do as healthcare providers, how we should limit our prescription writing, as well as the numbers that we're doing. Law enforcement, of course, are addressing our pill mills, and then the prescription drug monitoring programs and plans. We are aware of the Kentucky licensure initiatives, the House Bill 333, it directs the licensing boards of controlled substance to actually limit the number of days. There are exceptions that are available on that. And then we need to look at minimizing unused prescriptions that aren't properly disposed. How can we get rid of those? People are interested, they want to know about it, but they don't know exactly what to do. So we need to get better in terms of offering some ability to be able to get rid of these prescriptions. 69% of a 1,200 group that actually was surveyed felt that having a safe and secure way to dispose of leftover unused prescription drugs would definitely help combat the opioid epidemic. So some disposal options. One is you can find a disposal location by zip code. You can get on the DEA website, type in your zip code, and it'll give you a list of pharmacies that will take back your medication for you. What I've started to do in my practice is I actually talk to my parents about it, and I tell them, if you're going to pick up the prescription, take your old one with you, and then you can drop it off at the same time. You can contact the DEA's Office of Diversion Control. There's a call center. And then, of course, there are home disposal options. These are some options that people individualize. These are not always the best recommended. It is what people are using. There's a huge debate now on what to do with some of these medications. So mixing with kitty litter, coffee grounds, and then of course flushing. Now remember, when we flush it, then you get into the environmental impact of flushing your medications down the toilet. The FDA, though, has published a paper, and they listed 15 medications that they felt were flushable. Opioids were part of that. You can look at the paper. I actually have a slide that has, if you all want to reference it. But again, this is a safer alternative to get rid of the medication versus keeping it in your medicine cabinet for a prolonged period of time. As I alluded to before, dropping it off, looking at where and how to dispose. Again, FDA.gov, you can look at the DEA diversion. And what we're asking you to do is look at resources for your office. We have the Doterra system available. So on the bottom here, if you all want to take a screenshot of that Kentucky AAP, you can actually send us a request and we will mail you the Doterra Kit. These are small kits. It's based on a charcoal system. It's perfectly safe to have around children. And again, if you all send us a request, we will mail you these kits that you can have in your office, you can have in your schools, you can have to pass out to parents. There are some pharmacies in the state now that are passing out a disposal kit at the same time that they are giving someone some sort of a opioid analgesic. So contact information, you can contact me, my personal website, email address, I should say, patpurcell@twc.com. And then, of course, you can contact me at the Kentucky AAP website. We would be happy to speak to anyone that you all would like. This is part of our mission, is to really try to focus on adolescents and try to focus on limiting their exposure to opioids. Thank you.